All right, so I'm just going to say good evening to everyone. We are starting a bit late. We are doing our best with this technology. Welcome, everybody. We are so pleased that you can join us, and we are delighted to have Dr. Gaynor Watson-Creed with us as well this evening. First of all, I want to introduce myself. I'm Sharon Davis-Murdoch. I'm the co-president of the Health Association of African Canadians, and Rhonda Atwell is with us on this as well, and she's going to help me kind of guide us through. We're sort of co-hosts here, and then I'm going to ask for Dr. Gaynor Watson-Creed to introduce herself. I don't suppose she needs that much of an introduction, but I would appreciate it if she would inform all those on the call about her title and her role, and then Dr. Haase after. And if we connect with Dr. Milne and Dr. Cookey, they can as well. So
Jacob is on.
Excellent.
Yep.
So over to you, Dr. Watson-Creed, if you would mind sharing with us your role, your title and your role.
I think Gaynor is on mute.
Yes, I can't hear her.
There's a funny icon there. Gaynor, I'm sorry, we're not here. Can you hear me, Gaynor? We're not hearing you.
I see her.
Okay.
Can you hear me now?
Yes, great.
Okay, great.
Yeah.
Hello. Sorry to be late. And it's lovely to look at the participant list and see so many people I know but haven't seen for way too long. So nice to see you all, at least this way on Zoom. So for those of you who don't know me, I am Gaynor Watson-Creed. I'm the Deputy Chief Medical Officer of Health for the province of Nova Scotia. So I'm a public health physician by day and by night these days, but also hold a couple of other roles. I'm Chair of the Board of Engage Nova Scotia and an Assistant Dean at Dalhousie University's Faculty of Medicine. But we can talk about that another time. So tonight I think we're going to talk about coronavirus, but before we get into that, I'll let Dr. Haase introduce himself.
So I am David Haase, retired physician, and I'm a member of HAAC and working right now with a community project, the Nova Scotia Community Alliance Project.
Thank you, David.
Okay.
Dr. Cookey, could you introduce yourself?
Sure. Yes, my name is Jacob Cookey. I'm a psychiatrist. I work in community mental health at Cole Harbour, also a board member of HAAC, and also work closely with the Nova Scotia Brotherhood Initiative.
Terrific. Thank you. Now, Dr. Milne, I don't think it has joined us as of yet. Is he online? Maybe not. Okay. When he will, when he comes, we will certainly add him and ask him to introduce himself. So,
Sharon, can we just pause a sec?
yes.
I see several messages of people aren't able to get the audio.
Oh.
Well, anyway, hopefully, I just sent a message. Hopefully that will work to leave the meeting and then rejoin. Anyway, let's.
This is Lynn. Can you hear me?
Yes, we can.
Yes.
I didn't think I could either, but if you scroll down to the bottom of the screen and bring the screen up, there's a mute and an unmute there, which you don't see if you're just looking straight. You have to actually scroll it up.
Okay. Thank you. Okay, hopefully people will be able to hear it soon. All right, because time is ticking away, I think we should go ahead. And obviously there is much interest from community members, from everybody in the world, really, about what this virus is all about and how it how it impacts people. But we, from the Health Association of African Canadians, are very interested in having people of African ancestry have an opportunity to talk about it, ask questions in a safe place with providers who are responsive to us, who understand the importance of cultural competence, and we can talk. We're going to explore the impact of this virus on our health overall. That is our physical, our mental, and our spiritual health. So I think that's enough for me on that point, and I will ask Dr. Watson-Creed to kind of share the key public health messages about COVID-19, the things that we absolutely need to know. Over to you, Dr. Watson-Creed.
Okay, I'm going to try and distill as much as I can into about 5 minutes so we can get on to sort of the question thing. So I think, clearly everybody has probably some sense of what this virus is, but just to sort of back it up. Coronaviruses prior to this were known to us. So this is not the first time public health has seen a coronavirus. It's not the first time public health has seen a coronavirus epidemic of some high proportion. So this particular virus, the one that we're calling responsible for COVID, which is the disease that we say the virus is causing, is related to the SARS virus and to the virus that caused what we spoke of as MERS. Folks will remember hearing about MERS maybe 6 or 7 years ago now. That was a Middle East respiratory syndrome that was happening in Saudi Arabia and other parts of the Middle East. And so what's interesting about coronaviruses is that they're also related to some of the viruses that cause the common cold. And so they circulate broadly around the world in a variety of forms every year. But those three, SARS, MERS, and now this COVID-causing virus, have been particularly difficult for human populations. So in this particular case, with the one that we're looking at now, a few things are interesting. Number one, coronaviruses often don't confer long-term immunity. And so although we've had exposure from seasonal cold coronaviruses, SARS, and MERS in the past, we don't seem to have residual immunity from those exposures for this particular event. So we have a high proportion of the population in the world that is susceptible to this, and that's why we're seeing so much illness. This outbreak started in China. Folks are aware of that. At the very end of December, we've been watching it sort of tick along. China's outbreak lasted about 10 weeks. They're now in a period sort of between either at the end of their outbreak or between waves. We don't know yet whether or not they'll have a second wave of this. But 10 weeks was about the duration of that event. Here in Canada, the virus has finally arrived after making its way sort of across Asia into Europe and then ultimately to the United States and now to Canada. We here in Nova Scotia are in week 1 of having seen the first confirmed cases of coronavirus here. Our colleagues on the West Coast are in week 9. And what we're trying to do with this is to prevent the serious impacts that we saw in China and now in Italy and other parts of Europe from this disease. So you'll hear people talking about flattening the curve. And I wish I'd had the opportunity to put together a curve for you so that you could see what we're talking about. But what we see with these types of outbreaks is that you start with getting 1 case, 2 cases, 5 cases, and it starts to tick upwards over time. The faster it goes up, the harder it is for the health system to cope. And in this particular case, what's concerning about this virus is that people are being hospitalized at higher rates than we see even for influenza. It's not the same as an influenza virus. I want to point that out. And it is behaving very differently than we normally see influenza viruses behave during flu season. So up to 20% of people who get coronavirus will be hospitalized. And that's causing significant concern for our health systems who need to have the room and space to admit those people and then manage their symptoms at that point in time. So we knew this was coming. We had the opportunity of watching the Chinese outbreak in particular and starting our preparation even as that outbreak was still sort of full-blown. And as it arrived in Canada now, our preparation has really been about making sure the hospital system is ready. To do that, a big part of our effort is to slow down the transmission of the disease. This is where the difficult decisions over the past week in the province of Nova Scotia have come from. This virus, we don't believe, spreads asymptomatically. In other words, if you don't have symptoms, A, you're not likely to have the virus, and B, even if you do have the virus, you're not likely to be sharing it with others in any significant way. But where we see the virus take off is when it has the opportunity to mingle in groups of people, and it does take off in those settings. And so in every jurisdiction around the world, in order to get ahead of the transmission of this disease, we have called for halts on public gatherings and social distancing measures that are unprecedented, I would say, in modern times. We haven't seen this level of attempt to try and contain a virus. It's because we know that that hospitalization rate is high. The death rate from these, because I know folks are always wondering about that, is not as high as it was for SARS or MERS, so that's good. The other coronaviruses that we've seen serious epidemics from. So by comparison, SARS had about a 10% fatality rate, so 1 out of every 10 people who developed SARS would die. This one is more in the order of about 4% right now, and we continue to watch that. Some of that is actually contributed to, in this particular case, by the failures of health systems that are overwhelmed by the presence of the virus in those communities and can't cope with the number of people coming in. So it's not necessarily that the virus is that lethal, it's more that the health system actually just can't get to people fast enough because there are too many people in order to help them, and so they die not because necessarily the characteristics of the virus, but also because the health system wasn't able to get to them in time. So this is where that flattening the curve piece comes in. Our attempts in Nova Scotia around reducing the opportunities for the virus to spread between people are meant to slow down the rate of rise of that curve that I spoke about, and actually lower overall the number of people who were affected by this virus. It means that we might have a longer epidemic than China did. So BC's in week 9, and they're only starting to see, I think, the top of their curve. So that feels to me like BC's measures are working around this. So they're likely to have a longer curve than China did, but it will also be probably a flatter curve in that they won't see the high numbers of hospitalizations and serious impacts that China did. So that's why we're doing what we're doing. It is the first. This is my 3rd pandemic in my career as a public health physician. We have talked about using these measures for the other pandemics, for SARS and for H1N1 even, and it's lovely to be, I have to say, last jurisdiction in the country to experience this one as opposed to first in H1N1, so that's been good news for us as we got ready. But this is the first time, we've always talked about using these measures, it's the first time I've seen us use them. What's interesting is that as we compare jurisdictions who use these types of social distancing and mass gathering measures aggressively against those that did not, we do see that the curves are flatter in those countries that actually applied these measures stringently. That's why you've seen Dr. Rob Strang, who is the Chief Medical Officer and the physician that I report to, every day on the news sort of talking about what those measures are and why they're important to keep in place. It's because we actually are going to rely on them in this outbreak in ways that we haven't relied before. And to be clear, we do not have a vaccine for this like we do for influenza. And we don't have treatments for this yet in hospital. The treatment in hospital is really supportive care and doing the best you can to sort of support people to get through their symptoms and to the other side of disease. So without that, these social distancing measures to prevent disease become even more critical. Sharon or Dr. Haase, is that what you hoped I would start with?
Absolutely. That gives us a nice overview. I think people are very concerned about what they can do. We have heard, at least some of us have heard over and over again, the importance of hand washing, not touching your face, social distancing. Those people who have traveled, that there is 2 weeks of voluntary isolation. But if we were to drill down in very sort of practical ways, and I want to encourage my brothers and sisters online that no question is a stupid question. So I'm going to ask the first stupid question, okay? If you're talking about washing your hands, we know that we know that it's important to wash your hands, period, for hygiene, for before you eat and so on, and certainly after the washroom and so on. But the connection between hand washing and not touching your face isn't absolutely clear. So can you explain that? My understanding is you wash your hands and then you wash your face. So we touch our face for many things. Women want to put moisturizer on and so on and so forth. So what is the proper way to wash your hands? What is the proper way not to touch your face? Can you tell us a little bit about that?
Yeah, so I'll do my best. It's a great question. Thank you, Sharon. So a couple of things. When this outbreak started, the media was full of images from countries in Asia where people were wearing face masks, right? And that was the predominant image around how this virus was being sort of portrayed to North America. That has left people with the impression that this is an airborne virus, and I want to be very clear with the folks on this call tonight. It is not airborne. We do have airborne viruses. Measles is one of them. Coronavirus is not like that. Coronavirus, so that means that the droplets that come out when somebody coughs or sneezes or is a face talker and is right here in front of you. In the case of measles, which is airborne, those droplets are very, very, very light, and so they kind of make their way up into the air, and they will stay there for a long period of time, and they can travel far as a result of that. So we get very nervous, for example, when we see measles on an airplane, because the potential for those measles-infected droplets to reach other people can be quite high in that setting. The coronavirus droplets are actually quite large by comparison, so they may come out, but they fall relatively quickly. And they fall generally within a 2-meter radius. So that 2-meter rule that you hear people talk about, that's why that's there, is because if you're not within 2 meters of somebody, chances of droplets leaving their mouth or their nose and landing on you are pretty low. They will land on the surfaces that are around that person, though. And here's where you put yourself at risk. If you touch that surface and then bring whatever you've touched into contact with your face, you run the risk of introducing the virus through basically your mouth or nose or eyes, right? So that's the connection. So when we talk about hand washing, it's because we know that there's a potential that by touching those surfaces that were in that 2-meter zone, you've now picked up the virus on your hands. You're either going to give it to somebody else or you're going to give it to yourself by touching your face. The challenge around touching your face is that we do this all the time, right? So I heard one estimate that was something like close to 90 times a day, people will touch their face. You have an itchy eyebrow or your eyes are watering or whatever it is. And so the real key is to make sure that your hands are clean before you touch your face, and to be very, very mindful then of washing your hands all the time, right? If any of you has tried to do the exercise of not touching your face, and I challenge you to try this, I've tried it so many times in the past week, and I don't think I've lasted more than 5 minutes. It's just something we do, right? So the trick then becomes relying on your hands being clean, because moderating that behavior around your face is much harder to do. Does that make sense?
That really does. Thank you. And I'm going to ask, actually, David is online. I'm going to ask him about the social distancing piece, because certainly for people of African ancestry, we love to hug, we love to touch, we greet that way wherever you are in the world. Social distancing has a particular cultural barrier for us, or keeping social distance is a barrier. David, can you speak to what you would recommend around that, and also, if you're going to a funeral or something like that, what is the behavior that we can do?
Well, so thank you, Sharon. Gaynor explained the rationale, and I think this is a very, very difficult one for many people, not just those of us of African descent. And as you've said, we like to be close with each other. We greet each other with a hug and handshakes and those kind of things. Unfortunately, in this time, with this virus spreading through the community, I think we all have to be aware that the way to slow down the spread is, unfortunately, we'll have to stay away from each other. We'll have to wave at each other. People talk about elbow bumping, but the key is that distance between people, where if one person has the infection, the likelihood of passing it on to other people is much reduced by the distance between them. So of course, you have a wedding, you want to have your guests, you have a funeral, you have a wake even before the funeral. Those are difficult times. And I think we all have to be aware now of the number of people who gather for these events, even meetings, because it defeats the purpose of attempting to slow down the transmission if we're getting together in large groups. And of course, we talk about the impact that this virus will have on our community in terms of other things that are going on in our community, the socioeconomic challenges, the food insecurity, the systemic racism. There's so many other things that we have to be paying attention to. And then along comes this virus. And so, this is a big hit for us to have to deal with these issues at the same time. So basically, I don't think there is any way around it. I think we just have to be aware and to protect each other. So if someone knows that they're unwell, stay home. Don't go out, don't see anybody. Stay home until you get better. And if you're a risk, like if you've traveled and you may be a risk of having it, but you're not sick, stay home for that 14 days. And I think, Sharon, those are the things that will help all of us if we can manage.
All right, thank you so much. Sister Rhonda, you're on the line. Would you, I know that Dr. Milne is not, or at least I don't think he is.
I think he is. I think I see him there. Yeah, he is
Dr.
there.
Milne? Okay, great. So Rhonda, over to you with questions to Dr. Milne.
Okay, wonderful. Thank you, Sharon. Yes, hello, everyone. So Dr. Milne, we wanted to ask you some questions around signs and symptoms. What do you do if you have mild symptoms that show up, in your opinion?
Everybody hear me?
Yes, thank you.
Okay, good. So I'm Ron Milne. I'm the physician for Nova Scotia Brotherhood. In general, I think there are a few important points. Number one is no symptoms, no test. In other words, you don't need to be tested if you're not symptomatic, even if you've maybe had travel or contact. You need to do that self-isolation for 14 days. That's important, but you don't necessarily need to be tested. Another important point, which I'm hearing from some primary care offices, is to people, do not show up at your family doctor's office expecting to be seen. You have to go through the usual channels of calling, going through the screening, making an appointment, because there are cases where people are coming in supposedly for another reason, and actually they've got a cold or they've got respiratory symptoms and they want to be checked for that, but they haven't told anybody. So that's a really important point. As far as symptoms of the disease, about 80% of people have mild or moderate symptoms. The majority of people, I think up to about 90% of people, present with a fever. Cough is quite common as well. And but there can be other symptoms and shortness of breath, of course, if things progress into the lungs further. Some people can present with abdominal pain, diarrhea, nausea, aches and pains like you would have with the flu. But really the important thing is those respiratory symptoms, the fever, cough, and shortness of breath. So I hope that answers.
Yes, no, thank you. Thank you. I'm also hearing now too that some other signs and symptoms are being added, like sore throat, which wasn't originally talked about, but they're now saying that sometimes a sore throat can be a symptom as well. And when do you—
Runny nose, sore throat.
Yes, all of those. But I guess people are particularly concerned about when they should call 811, for example. And when should they call their family doctor? And how are seniors impacted? So those are three different questions. But
Okay. So the 811 number has been set up as a screening and information source. And though I understand some people have been having trouble accessing that, I don't know if Dr. Watson-Creed can comment on that later, but there have been problems with it. And through the family doctor's office or through 811, then referral can be made to the COVID assessment clinics, which at the infirmary and Cobequid, I think, is another one, maybe one other one as well. And there are different ones around the province also. I think in general, if you have concerns, then calling the family doctor's office, there'll be a screening, some screening questions asked about fever, travel, contact with people that might have the illness. And from there, then people are triaged. The other thing is, I mean, life is going on. There are still people that are getting the flu, that are getting other symptoms, that need their blood pressure checked, that have, their diabetes problems. So, we're still seeing a broad range of problems. But I think in general, it's those respiratory symptoms right now that people are focused on. And in some cases, the family doctor, if there's a high suspicion that the person might have the disease, they may be referred directly to the COVID centers to be assessed there. The other thing that I didn't mention, family doctors do not have the testing kits in their office. So you cannot be tested in your family doctor's office. So if you're coming there with the idea that you're going to have these nasty swabs put down your nose, no, somebody else is going to do that. But, and that's, again, is at the screening centers or in the ER, though we're encouraging people not to go directly to ER unless they're very, very sick, because that's going to create a bottleneck there as well. The other question about seniors. So yeah, seniors are a special group. We know that this disease is affecting everybody right across the spectrum, from little children to adolescents to young adults. I think a number of cases that they've seen are between age 20 and 44. So this is not just a disease of elderly people, but the elderly do pose a special case because of mainly their susceptibility to infections, given that as you get older, and I'm putting myself in that category, that your immune system is not as strong as it was when you were younger. So that creates a real setup for possibly more severe disease. And unfortunately, a lot of the mortality has been in elderly people, both in China and in the US, but also people with underlying health conditions, respiratory conditions, heart problems, hypertension, diabetes, people with cancer, people on immunosuppressant drugs, or with immunological diseases. These are all people that are at greater risk. And so I think, more care has to be taken. Unfortunately, with some of our seniors, they're more isolated in some ways. They don't have as many people around them. And now with church and community gatherings being limited, it's very, very hard on older people who maybe can't get out and do the things, the social activities and things that would normally keep them going. So I think that's a special thing as well. I think as far as in general, there are certain things, we don't have a cure for this, we don't have a vaccine for it to prevent it, but just in terms of trying to keep your immune system as strong as you can, drinking lots of fluids, water especially, trying to get as much sleep and rest as you possibly can, eating a healthy diet with lots of fruits and vegetables, which are sort of natural immune boosters. You know, these things, they're common sense things. We don't have any evidence to show that they do prevent COVID-19 infections, but I think it's just wise to follow that kind of advice, along with, of course, the social distancing and the hand washing particularly. Yeah, that's.
Yes, thank you. Thank you, Dr. Milne. There's a few questions coming up, so I don't know if we want to take some of those questions or if we want to wait.
Probably it's a good idea to answer some of those questions now. Yeah.
Okay.
Did you see them, Rhonda? Are you?
David, do you see them? I'm seeing, wait a second here.
I'll just jump in while you do that. There was
Sure.
a question about sarcoidosis.
Oh, yes.
And you know, all of those things that are chronic diseases. I wonder if Dr. David or Dr. Ron could sort of give a description of chronic disease and why, you know, those folks may be more susceptible. Yeah.
Yeah, some of the things that I mentioned already: diabetes, immune system diseases, cancer, of course, is a big one that those people are immune suppressed, particularly if they're on agents or drugs. Some people with illnesses like rheumatoid arthritis or lupus that are on these biological agents, also ulcerative colitis and Crohn's disease. Sarcoid is it's sort of a special category. It's a disease which actually is higher in the African population in general. A lot of people in Nova Scotia have sarcoidosis, and it's a disease that affects a lot of different organ systems, particularly the lungs. And of course, anything that affects the lungs is going to put you at higher risk, not necessarily of catching the disease, but if you do get it, you have more risk of complications and more severe disease. Also, people with sarcoid are on drugs like prednisone often, or immunosuppressant agents. These drugs sort of dampen down the immune system and weaken it, so that, again, if you are unfortunate enough to catch the virus, then the chances of having more severe disease are higher.
There's a sorry, go ahead.
David, please, Dr.
Yeah, no, I'm just going to say, I mean, I can take a couple of those questions, and Gaynor, please jump in as well. The issue of social distancing and the need to slow down transmission is what has led to the sort of mandate to stop having meetings in groups like church, and we talked about having, gatherings at funerals and weddings, etc. And I think in terms of how long that will go on, it just depends on what the course is through our community. And we need to know that public health is right on top of this. We can be guided by them. They will let us know when they think it is safe and appropriate to resume those kind of activities. And Gaynor, I say you can jump in anytime. There's a question there about, you want to jump in on that, Gaynor?
Sure, just to say that, so I started by saying that the outbreak in China was 10 weeks long. And currently BC is not at the peak of their outbreak activity, we don't think, and they've already been in the outbreak for 9 weeks. This is an event, I hate to be the bearer of bad news on this, but this is an event that will take us into a duration of weeks and probably months, not days. So the measures that we've put in place now, even until the end of March, we will be reassessing on a regular basis, but I don't anticipate a return to business as it was, 2 weeks ago anytime soon.
Okay. There's so one of the things for us is that we have been quite late in this relatively, and so we've been able to observe what has happened in other countries. And so if everyone thinks about that 2-week rule in general, so what has been seen is that people who develop this or who get this infection, usually within 5 to 10 days will show symptoms if they're going to show symptoms. But the 2-week window is really the sort of outside sort of window for people to develop symptoms. So this is not a virus that's going to stay dormant for weeks and weeks and weeks. I think what is happening is that there are many people who have this infection who have very mild or maybe even no symptoms at all, and they recover. But again, that 2-week window is there because of the risk of transmission when somebody becomes unwell. There is the narrative of Black people being immune, and again, Dr. Ron spoke to that. And there is nothing in us, color of skin, whether we live in a hot climate or if you look at what's happening around the world, Black people in Africa, the Caribbean, wherever they are, in America, we're all affected as well. So nobody should be thinking that because you're from a certain ethnic group that you're immune to this.
Yes, David, can you expand a little bit on that, especially when you talk about the virus and being exposed to heat? One of the things we're hearing a lot from community as well is that once summer hits, that somehow things will slow down because the virus can't live beyond 26 or 27 degrees. If you or Gaynor,
maybe you want to address that?
Yeah, so certainly we're not seeing wide transmission of this virus in southern climates, but we don't know if it's because of temperature. So it may also be that folks are outside more, and certainly I think I've already described that this is a virus that loves to see people in groups, and indoor groups even better because that's how it transmits the most efficiently from one person to another. So in hot climates where you're outside more, you may also be spread out more, and so that may have a protective effect, but it is not solid evidence. I wouldn't hang my hat on that yet. In fact, the worry that I would have right now is that we don't know whether or not we will see a second wave of this virus when winter hits again or when the fall hits again. So we may go through this wave, we may flatten the curve for this wave, and have relatively few infections, for example, compared to what China or Italy has experienced. But it remains to be seen as to whether or not that means the virus is completely gone, or if we don't see it in the summer, if we'll see it in the fall after that. Does that answer the question?
Yes. Yeah. Thank you.
And if I could, there was a question too with respect to when you recover, is there permanent damage after you recover? I mean, is there something that lingers? If Dr. Watson-Creek could tell us about that.
Yeah, so the answer is in terms of the virus lingering and you being, a risk to other persons still, the answer is no. So when folks get the virus, generally speaking, we believe that they stop being a risk to others about 10 days after their symptoms started. And so we're now making decisions to tell people that they're safe to resume their usual activities within the confines of the recent restrictions we've put in place. If they they had symptoms on day 1, 10 days later, they're feeling much better, then we would say, okay, you're good to go. You're not a risk to anybody else. The residual impacts beyond that for the individual who was sick depend on how sick they were and how much additional recovery they may have to do. For example, if they were hospitalized or if they were intubated, recovered from that, and are extubated now, but they still are recovering from their illness otherwise. So all of that is still possible, just as it would be for any other hospitalization.
And the related question is the whole issue of immunity. So what we know is going to happen. So right now, this viral infection has taken the world by storm. And one of the major factors is that none of us have immunity. Eventually, in time, and we don't know how long it's going to take, we're going to build up a community, sort of what we call herd immunity, which will help to slow down transmission. And so a question is, once somebody becomes infected, the pattern is that they develop immunity, and that will protect them against reinfection. Now, if it's like influenza and it mutates, then that's a risk for reinfection. But the way the virus is right now, once somebody has it, we expect they'll become immune. There are issues there, questions there about drug therapy. People are looking at all different kinds of drugs, and we don't have any specific ones right now. So, and vaccines are being looked at as well. And again, that's going to take us a while to get to a vaccine. And special protective measures, I'm not sure. Gaynor, you might want to, and the state of emergency, as you know, Gaynor, that was declared today, right?
We have, unless I missed it, we have not declared a state of emergency in the province of Nova Scotia.
No?
I don't think. You know what? I have been missing the daily press briefings lately, so if I'm wrong about that, you people let me know because I may actually have missed an announcement. And so just to address that one first, I think we are now up to 6 provinces that have declared states of emergency around that. It's possible that we would declare a state of emergency in Nova Scotia. We are basically operating at this point as though we are in a state of a public health emergency. Thank you for the clarification.
Okay, thank you.
Okay. So she says, no, we haven't gone there yet, so I didn't miss it. We're basically operating in Nova Scotia as though we are in a public health emergency. We have not made a formal declaration about that, but when you look at all the measures we've put in place, in fact, we're behaving very much that way. A state of emergency beyond that would be around now mitigating all of the outside effects that this public health event is happening, right? So to the extent that this public health event starts to affect people's capacity to get food because food is not coming into the province in a way that we can now rely on the way we once did, that becomes something that the Premier, for example, has to look at and say, okay, do I declare a state of emergency so I can manage that impact? Or the impact on telecommunications infrastructure. I don't know how many of you are experiencing slowdowns in your internet and Wi-Fi service since we instituted this mandatory social distancing. But what's happening is everybody is at home on their devices, so all of a sudden the demand on those systems has gone up. So if that creates an unsustainable or unstable situation for Nova Scotia, those are the types of ripple impacts that might create a state of emergency beyond the public health issue. With respect to the special protective measures, yes and no. Thank you, Isaac, for the question. You know, we're certainly having conversations about what are the, I hate to use the term equity seeking, but I'm tired and I don't have another term at the front of my head, and I feel like we're not seeking equity, we are kind of demanding it. So anyway, I won't go there today. But for those groups that are at high risk for all kinds of outcomes because they experience inequities, it's a constant conversation, I would say, in the circles of people that are managing the coronavirus. At the end of the day, though, the intervention that we are talking about, right, and in particular, I'm going to say that homeless populations are a real challenge around this, because particularly with the shelters, how do you reasonably implement social distancing in those environments, and also support the other needs, very, very high needs that those clients have when they come into the shelter. But aside from that, the measures that we're talking about actually are applicable and to some degree accessible at almost every sort of social and economic stratification, basically. So hand washing and or keeping clean hands and respiratory etiquette, you know, to the extent that folks can practice that, we're encouraging that. and the social distancing and the avoidance of mass gatherings, those are kind of the cornerstones of this. And so to the extent that we can support groups to do that, we're looking to do that. But, you know, it's an evolving situation, I guess is what I would say around that one.
Can I just jump in and have Rhonda speak to Dr. Cookey about mental health issues?
Yes, no, I know. Thank you, Sharon, because I know that time is ticking here. So, yeah, so Dr. Cookey, if you can speak to some of the mental health impacts or the impacts of the virus maybe on our mental health and wellness, especially considering us all now being isolated and social distancing, it can be challenging. So if you can speak to that, that'd be great.
Yeah, sure. So one of the other things to consider is, of course, our mental health. So this is a very, you know, it's a worldwide event, you know, once in a lifetime type event. It can be very traumatic for a lot of people, especially if you have already pre-existing mental health illnesses. But even for all of us, I think the number of people on this call speaks to our collective anxiety about this. So, so just like our physical hygiene we have to attend to, we also have to attend to our so-called mental hygiene, and these are, I think, things that will kind of, you know, keep us sane through like Dr. Watson-Creed said, it could be several weeks or even a couple of months that we're kind of living differently. We're social creatures. We're creatures of habits, and now we're forced to socialize differently, and our habits have changed. So these can have a major impact on mental health, and especially for example, children. So you know, children at home. There's a lot of studies about this, even in the summertime outside of school, where things change, when routines change, how it can negatively impact them. More screen time, more anxiety, more disturbed eating schedules, sleeping schedules. So some of the things we try and tell people, especially in the clinic, is, you know, as much as humanly possible, keep a routine. We are creatures of routine, and we ought, as much as possible, to continue that. This includes our circadian, or so-called circadian rhythms, the sleep-wake cycle. Our eating cycles are very important to attend to, and moving. So we can't forget this. It's so important. If we stop moving, we start to decline, both physically and mentally. So it's as much as possible to move, to walk, to get out. It's okay to get outside. The key is, again, the social distancing. So as much as possible, getting out is a great idea. Older adults, especially those with dementia, this can be extremely confusing in difficult times. Irritability can get a lot worse, a lot more anxiety. Again, the routine is the routine is changing. So as much as possible, we have to be there to engage and help and support our seniors. Other practical things that I'm doing a lot in clinic is, you know, patients, instead of making them come into the clinic, I'm trying to do it by phone or by video chat, loading them up with their medications, so, you know, 2 or 3 months supply instead of, you know, every few weeks or every month, to reduce the number of times they have to physically come in to contact with other people. And then the other side is, you know, we're also spiritual beasts. So spiritually, you might say we're in the, you know, the valley of the shadow of death, as it were. But it's very likely that most of us will get through this just fine. And it's important to speak about that and engage in our spiritual side of things, reading the Bible, the Quran, prayer, meditation, engaging in these things that are higher, that no bug can touch, you know, these higher levels of thoughts and prayers and philosophies that we all have. I think that's very important to hang on to and nurture. And, you know, when we get to the other side, I hope we'll be that much better.
Yes. Thank you, Jacob. I just wanted to speak a little bit to the need for us to stay connected as well for our mental health. I know that it isn't easy right now, but as much as possible, if we can keep engaging, the importance of engaging. Would you say, Jacob, would you want to speak to that in terms of its impact on our mental health and well-being? Because it is changing the way that we do things in the community, the way that we greet each other, the way that we communicate. What can you say about that?
Absolutely, absolutely. So I think that's a great point. So it's almost a misnomer. I don't like the social distancing, physical distancing, but you want to get as close as you possibly can on the social, emotional level with all of those that we love through things like telephone, FaceTime, these things. So yes, that I think that's important in order to, again, as I mentioned earlier, we're very much social creatures. It's it's the reason why in prisons they limit how long you can have in on yourself in isolation. We thrive by connecting with other people, and I think that's even more true in some ways in the Black community. I think that's very important, and I've been actually pretty proud of how just out and about when I have been out, how people have been engaging in physical distancing, and I've seen a few people I know from the community, and they've been doing the elbow bumps or the foot bumps and respecting each other's distance. So I think I think there is a lot of hope.
So thank you very much, Dr. Jacob. And I want to thank everybody. There was a question that came in, and I'm just going to take like 5 seconds about this. If people are wondering if you...
Sharon, can I interrupt you for just 1 second?
Yes,
I've extended the meeting until 6:30, just in case we want to.
Oh, good. Oh, okay, great, fabulous. Okay, well then I will fully ask the question then. Senator Wanda Thomas Bernard wanted to know about co-parenting. And her question was, how are parents who share parenting managing through the crisis, and what should they be doing? Should the children continue going to both parents' houses, for example? Any advice and direction on this would be helpful. A similar question would apply to grandparents and other caregivers. With schools and daycare centers, it is challenging for many parents. So, Dr. Watson-Creed, Dr. Haase, what would you say?
Yeah, and I'm going to put my hand up for the co-parenting challenge because I'm doing it right now. And it's not easy. My kids are home. My partner's kids are home, and they both have other homes with the other parents that they can go back and forth with. And my ex-husband is in quarantine because he traveled from the U.S., so yay for that. So it creates a huge parenting challenge and a huge parenting mess, and that's for me where I've got some resource around me. If you are low resource, then it can really be like on top of all the other stress of the environment, the mental stress of figuring out the childcare can be huge. What I've been saying about all of these, and I see that there's another question about, if somebody's returning home to self-isolate and they live with other people, and especially if those people are immunocompromised, how do you manage that? Within the home environment, I think every situation is going to be unique. And so the challenge is this: you want to keep individuals away from other individuals as much as possible during this time. If you feel like you can manage that with, for example, the co-parent. So in our case, what we've done is my kids are with me for the next 2 weeks. They forced, really, because my ex is in quarantine. But when he's done with that, they'll go back there for 2 weeks, but they are not having play dates in the house, which is hard on them. So they're relying on their smartphones, and they're relying on FaceTime and all those types of things to stay connected. We are doing that back and forth as long as I have an assurance that, lots of other people aren't entering into that house and vice versa, that he has the assurance that people aren't coming into my house randomly. Then we're trying to respect that self-isolation and social distancing or physical distancing. Jacob, I think that's a really important distinction. When it comes to other childcare providers being in the mix, I think it's worth being cautious about this. So in particular, grandparents, I think, are at higher risk right now than they would normally be. And so if I had to choose between sending kids to a grandparent versus finding another arrangement, I might be looking for another arrangement, but that has to be family dependent, because you may not have another arrangement, in which case it's do the best you can. And everybody is washing their hands, and they are monitoring their symptoms, and if anybody looks symptomatic, you are changing the arrangement because you want to protect the other people. It basically has to be that. We can't create rules for every single situation, so folks will have to figure it out themselves. It's similar for the folks who are trying to self-isolate at home and they're surrounded by family members. If you live in a single-family dwelling and you've got multiple external exits and you've got a large master bedroom that you can accommodate somebody in and it has its own bathroom, that's one thing. If you're living on the 6th or 7th floor of an apartment building and it's a 1-bedroom and you've got a whole family in there, that's something entirely different. And again, it has to be do the best you can to keep the sick people away from the well people, and to isolate those droplets from coming into contact with other people. So lots of extra cleaning in the house, you know, again, lots of hand washing in the house, that type of thing to minimize the spread within the household. The high-rise buildings in particular are really tough. We are getting a lot of questions about that as people are returning from their vacations, for example, in the U.S. and finding themselves in isolation for 14 days, but they want to be able to at least get outside. But to be able to do that in an apartment building and make sure that you can get on and off the elevator if you're asymptomatic without coming into other contact people, into contact with other people, or the stairwell without coming into contact with other people, it can be really hard. And I'm not going to lie, you know, one of the tragic kind of downsides of this action is that, say, the kindness of Nova Scotians is not necessarily at the forefront of every interaction. So, you know, certainly I know in our Black community that we're going to be kind to each other and we're going to treat each other with respect, but that's not happening everywhere. And so that's some of what folks are facing as they're trying to navigate these situations for themselves. So it's not easy. There are no recipes, but the message I'm giving everybody is this has to be about all of us doing the best we can.
That's very helpful, Dr. Watson-Creed. And you know, you touched on something in terms of some folks not being kind to one another. There certainly is on American media this whole notion of blaming a population, being racist toward a population. And you know, we as Black people know that we have been blamed for all kinds of illnesses and all the rest of it in our past. And so, you know, we know what that feels like. Can you speak to the whole notion of illness as punishment? Is this something that you know, that has come up in your work in the past, and how do you speak to it?
Yeah, so Sharon, when you say illness as punishment, are you referring to, you know, sort of historical deliberate attempts to make certain populations ill, or are you talking about something else? Yeah.
I'm talking about attitudes toward people based on ignorance and discrimination and racism. You know, HIV comes to mind, that type
Yeah, so that, I mean, that has been heavily present, certainly since the beginning of this outbreak. I think as more and more populations around the world get impacted, there is lower and lower tolerance on the one hand for the, you know, sort of sifting of the illness by, in particular, ethnic and racial categories. What's emerging instead, though, is, you know, sort of, it almost feels like folks are looking to find any reason to blame anybody for having this illness. And in communities, that's playing out in a particularly ugly way. So we are seeing that. We are giving the message that actually folks do have to pay attention to that and be kind to one another around that. But what's happening is that we are seeing folks very publicly shaming people for having come in contact with the disease and being in isolation, or having the disease directly and being in isolation for that reason. And you know, I find it unexcusable. I realize that it's coming from a place of fear. So it has shifted. The targets of the blame have shifted as the outbreak has progressed, but it continues. Does that answer the question, Sharon?
Yes, I think it does.
I'd just like to add that the whole argument about blaming a disease on a country or a particular ethnicity, they need to go back and look at the fact that the US introduced Lyme disease and Legionnaire's disease to the rest of the world, and nobody's blaming them for that.
Thank you, Dr. Ron.
You're welcome.
Fair enough, fair enough. Are there any comments that anyone wants to make otherwise about perhaps helping people cope? Because this is something that seems to be evolving. People are sending messages to each other on social media and doing YouTube things to give people ideas about what you can do in this time when we are having to stay at home, and how to cope. As Dr. Jacob spoke about, having a routine being very important and so on. You know, since we have a few more minutes, would any of the physicians or anyone on the call like to share information about that or share thoughts about that?
Sharon, this is David. I would just like to emphasize a message that we need to get through this together. We need to look out for each other. And, you know, we all live in neighborhoods where there are other people, some of whom may be vulnerable. And, you know, just to look out to see how your neighbors are doing and if anyone needs help. People on isolation, self-isolation, may need someone to help them pick up their groceries or medications, or, I mean, we need to get through this together, and we will.
I would just like to add, please, people be mindful of where you're getting your information from, because there's a lot of misinformation going around right now, excuse me, on social media and the internet about cures, treatments, preventions, et cetera, et cetera, et cetera. And I think we shouldn't ignore the science that we know now that is working to help prevent the spread of this into the community, and that people should be aware and should be, you know, taking the precautions, the hand washing, the distancing, et cetera, and not looking for other things that are unproven.
Okay. All right. Well,
So Sharon,
yes.
if I may,
Sure.
there is a question there that maybe Dr. Watson-Creed might address about community member in a rehab that's coming out, going to be released. Gaynor, do you see that one? See there?
Yeah, I'm looking for it. Just okay.
Sort of
Yeah.
in the middle there, yeah.
Yeah. Okay. Yeah, community member in a rehab center that suffers from dementia and is scheduled to be released, and arrangements to stay. So I'm thinking that this is concern about hospitals being high risk or rehab centers being high risk for having coronavirus in them and not wanting to expose the family members to that. I'm hoping that I have the interpretation of that right. And what I would say about that is that, so right now we have very, very little coronavirus in our hospitals. And my hope is that we will keep it that way for as long as we can. This is in the same category, I think, as the other decisions. I think, I would consider certainly hospitalization right now to be a relatively low risk, but these are all going to be decisions that individual family members have to make for themselves. And I think to the extent that it works for everybody, and everybody feels supported in the decision, there are no wrong answers. So, you know, I don't know if that's helpful, but I think, you know, if you're making a decision that feels right for your family members and you feel sort of secure in the decision because it feels the safest for you, I think that's okay. You know, other families might choose differently. And, you know, I get the same question around, should I take my family members out of long-term care? And again, I put my own hand up for that as I think about an impending long-term care admission for my mom. And you know, what I might choose for my mom and my family and how to do that could be very, very different than what other family is able to choose based on their circumstances. So I think it's the type of thing that you really have to sort of make decisions around based on what works for you and your family, but I don't think there are any wrong answers. Certainly, I see in the question that you're questioning if it's the right decision. I would say if it feels like it works for everybody, then it's the right decision.
Could I just add one other group that we haven't mentioned that I think could be very adversely impacted by this in the community, a group that we work with a lot with Brotherhood, is those men and women that are incarcerated, because that's a big area that could potentially be a huge problem if we start seeing spread in some of our institutions. And unfortunately, probably the visiting restrictions now are going to be even stricter for those men and women who are really needing to be, touched by family and other people. So I don't think we should forget about that group.
Hi,
But-
this is
But go
Sharon.
ahead. Yes. Isaac, go ahead.
Yeah, sorry, I unmuted myself. A couple of things. I thought this. Thank you so much for everyone for organizing this meeting. And I posed the question whether we should consider doing this regularly. Not maybe every week, but maybe every bi-weekly. Because it keeps us connected, it keeps us informed, but the situation is going to change. And of course, as members of the Black community, one of the things we have to be very vigilant about is, us falling through the so-called cracks, right? I think I'm involved in similar stuff at Dalhousie University as well to ensure that African Nova Scotian students, right, are not forgotten as we deal with this major crisis. So that's one thing. I wanted to also talk what Dr. Haase was saying about helping people with the groceries and the medications. Halifax Transit is about to cut its service by 30%, I think, beginning this Monday. So much of our community use the public transit system to get from A to B, right? Even though there's less use, but some of them have to take it even in this crisis to get from point A to point B. So I think that's one thing to consider, right? Especially many people who are going to get, things like drugs and so forth, get to the pharmacy, won't have vehicles available. And at some point, I can see Halifax Transit even going shall we say, lower in terms of its services, perhaps even reducing it to nil, right? If that's a possibility. So I think we should bear all of these things in mind as well.
Okay, well, thank you. So, someone else wanted to speak?
It's just Robert here, Sharon. First, again, congratulations to HAAC, and thank you so much for organizing this. The question was asked, what can we do to cope and to get through this? I was thinking really in terms of one of the things that we need to do in terms of using this as an opportunity to see those areas in our personal lives and family networks and in our communities that may be broken or there might be weak links. The people who are in our lives that we're most concerned about right now are probably the people in our lives who we should be paying a little more attention after this crisis to. And those things that we are feeling that we are missing during this period of time are probably things that we should spend some time thinking about after the crisis is over, in terms of how we strengthen that infrastructure and how we create things for ourselves within our families and within our communities. So I'm thinking that this is a fantastic opportunity for us to share and to kind of just know that we're not in this alone. And that's very helpful to us for now. But I think after the dust settles, as a community, we do need to ask ourselves the questions personally. What in my family do I need to change so that we can function better through difficult times? And as a community, what do we need to strengthen so that we are better prepared the next time? So,
Thank you so much.
and I know that HAAC will likely be hosting those kinds of conversations.
Yeah, it's Gaynor here. If I could just add into that, and thank you, Robert, for those comments. And I haven't uttered this out loud yet to anybody, but here's what I wonder: if there's any silver lining or opportunity in a crisis like this. We are in a completely unprecedented state, and as we were talking as a public health team earlier this week, what I said to the team here is, we have turned the world completely upside down for Nova Scotians. So in that, I wonder if when the crisis is over, if the goal isn't for us to return to normal, I wonder if the goal is actually for us to return to better. And I don't quite know what that looks like, but I want to leave that as a question. There is so much in this that is just ripe for plucking that opportunity out and exploiting it. So anyway, just want to plant that seed.
Hi,
Well,
can people hear me?
yes.
Okay, I was having a private conversation with Sharon, but I figured I might as well put it out there. I don't know if it's at all useful to start developing a list, and I don't know where that list sits, but of people who are able to pick up groceries or pick up medications for folks, for those who are host-bound and won't have transportation. And you can simply call the pharmacy and leave somebody's name and ask them to have to show their ID if they're picking up prescriptions for you. And I think that we should try and start developing some type of network for that. And also thinking of one of those other health professionals, like, I mean, there's some great online resources that we can start looking at in terms of mindfulness, some great coping strategies around eating healthy, because I know that what often happens right now is we eat and watch TV, and most of what we're eating is not healthy, and our physical activity is very, very minimal. And we know that all of that stuff goes together in terms of physical, mental, and emotional health is so, so important. And even trying to get free access to online books. I was thinking about doing book drops, but then our books are already touched by other people. So it's trying to find other ways to do online readers or sharing access to some of those resources. And I think that we need to think of ways to communicate and differently. And even if we could even, those of us who have done mindfulness, even have like a webcast where we log in at 10 o'clock every morning for those who want to go through any type of mindful exercise. I just think we need to think more creative of how we can also support people's mental health and well-being. And responding to Ron's question, then I'll stop babbling, was about those who are incarcerated. I'm sure there's a way that if we could think about it, and Jacob, I know you've been going inside, or you have access, or other people have access and know how, where we can put some money onto some accounts for phone calls. Because we know that it costs money for people who are incarcerated to make phone calls. So is there some way that we can begin to set up? And I know that Lynn started an online a GoFundMe for Black communities, but we haven't thought about a GoFundMe for incarcerated inmates, where we can actually start putting some money into institutions specifically for Black inmates to be able to make phone calls to loved ones, since they can't get visitors.
Well, can you feel the buzz that's going on through our communities here? What a wonderful, wonderful thing this is, that we have connected to one another, and we're starting to think of all the good we can do. I'm going to wrap it up, but I will give voice to anyone out there who wants to take a few seconds before I do. Don't want to prevent anyone who wants to.
I have two questions I'd like to ask.
Yes.
I'm a person who likes reading the newspaper each day.
Right.
And I want to know whether you can catch a virus from getting the newspaper and opening it up and all that.
Good question. Our infectious disease specialist, please. Dr. Watson-Green.
Oh, yeah. Well, again, I mean, you can chime in here. I mean, the data shows that this virus can live on surfaces for hours, and it may be up to a day. I mean, the data is not all in yet. So theoretically, if somebody has a virus in their hands, touches a newspaper, and you pick it up right away, theoretically, you could pick up the virus that way. And that's why we have the emphasis on washing your hands frequently and not touching your face, eyes, nose, and mouth. So that even if that occurs, you're going to be washing your hands and you're not going to be touching your face. Does that help?
Yes, it does. And also, the fact that you can go shopping and someone else or a person with a virus could have their hands on the article that you pick up.
That's right.
Yes.
Same thing applies. You know, and I mean, we've run out of hand sanitizer, but for those who do have some secreted, you know, well, stored away, you use your hand sanitizer if you don't have access to soap and water. But the key is just to remember, you know, your hands can be contaminated at every turn. And so you don't want to transfer that to yourself or to somebody else. And Gaynor, you can go ahead.
Yeah, no, those are the messages. So when I go into the grocery store now, I am looking for the hand sanitizer dispensers. I mean, they're almost always empty these days, but I look. I take my hand sanitizer in with me if I remember to. I look for the wipes to wipe down the cart, and I'm sanitizing my hands when I get back in the car. You know, it sounds paranoid. It's not what we're used to, but in fact, what we've been saying all along is that if you do those things for this virus, it's actually going to help us for the next flu season too. Because we've been saying the same things for years. I think it's through this virus that we're actually seeing, oh, this is why we need to do that. The other thing I would just say, back to the social distancing, is we have had repeated opportunities to look at this virus and what it does when people get together, be it on cruise ships, in long-term care facilities, at parties, events, weddings, funerals, particularly in Asia. There have been some spikes in cases when they've allowed those events to go forward. And so, again, humans clustering together in really sort of any size group. We've said in the province of Nova Scotia greater than 50, but there's no magic to that number. Humans clustering together creates a real opportunity for this virus to spread to others.
Floydine, did you have something that you wanted to share?
Yes, good afternoon. I wanted to say thank you very much for including us from out of province in this call. It really speaks to what happens when we bring our collective wisdom and brilliance together to move forward, and wanted to say thank you for that. I also wanted to find out, and I put it in the chat, whether this call or the recording is available for us to share, because in all of the conversations that I have been a part of through work and through community, we have not had this level of information and content that could really be useful to move forward. And the third thing I want to say, we at CAFCAN have started some resources. Like I just posted something on activities and websites and YouTube links for parents who have children at home, for example, that we can share with others, and other things that we're doing, that you know, we can create something where this information is shared with everybody. Because I see what's happened here is a community of practice in the making, and Emmanuel knows that I'm big on communities of practice because they lead to best practice. So hoping that we'll be able to continue this dialogue on a regular basis as someone recommended. So thank you so much again for including us.
You're so welcome. Okay.
Carla, it's Emmanuel here also in Toronto, just without taking too much time, echo the sentiment and the comments made by my sister Floydine. Here, what we have done through the meeting of the minds, and many of you are part of it, on Monday this week, we hosted a national call on COVID-19 and Black communities, and we have identified a number of areas that require collective leadership, you know, and we're happy to share that we have also created a Google Drive with various resources for community-based organizations, for businesses, you know, and others. So I think it's great that you guys have organized this, and if we can continue to build on each other's strengths, then we will be better off in terms of protecting our communities as we move forward.
Okay, and thank you so much. Very welcome. You were very welcome to join us, and we're delighted that you have, and that we can continue to share across the country, and who knows, across the world. We started something here. So I really do want to take this time to thank my co-host Rhonda, to thank Dr. Watson-Creed, to thank Drs. Haase, Dr. Cookey, Dr. Milne. These are our HAAC family, you know, and all of you are our HAAC extended family. And you can get closer anytime you want, just join our organization. But I do want to tell you that we are going to have the audio of this available on the HAAC website. We wanted to do that right from the beginning because we know not everybody could be on the call, and we know that you could play this as much as you want. You know, if you want the answer to that question, you can hear it by playing this again. So we are going to do that. If you have more questions that we haven't gotten to today, please do write HAAC, or call HAAC, I should say. Go to our website and call HAAC. Our amazing admin assistant, Carla, will put those questions together for us, and we will be able to put information on our website. I hear the need for more and more and more and more regular calls, and we will take that seriously, and we will do all that we can. But I want to encourage all of you, all of our people tonight, to say to you that you know that we are among the most resilient people on the planet. We have been through all of it. We have survived, we have thrived, and we will do that again. Stay healthy, but stay positive and help one another. Thank you so much to you all, and we'll probably be back to you soon.
Thank you, Sharon. I just want to say quickly, this is David, that on the website, there's a contact form for questions or comments as well. So people can write in as well if they have questions.
Excellent.
Thank you.
Thank you, everyone.
Thank you. Virtual hugs to everyone.
Virtual
All right.
hugs.
I know.
Stay connected. Stay safe.
Good.
Night.